maybe I start with you as a group. So I don't know whether there's one person who can say this is something I learned now.
One important point was how much money in percentage should go to equality part. Should be 5%, 25%, should be around 5 to 7%. I don't know. It should be low, not giving too much wrong incentives to people. Too much.
Can we do a quick vote? Who thinks 5 to 7 is too high? 2. And who thinks it's too low? So the rest thinks it's about right?
How many don't know?
How many don't know? Sorry. 4. 5. Not applicable. Okay, well, that's a difficult question. And it gives an indication of what we think about what this group has brought up. Any other points?
We also discussed the lack of patient self-management in QoF. There are very few incentives which encourages patients to manage their own chronic disease or helps you to have that management. Because the numbers of patients with chronic disease is exponential, and the number of doctors will always be limited, and the health budget will always be limited. So if patients aren't involved in chronic disease management,
It's very difficult to incentivize self-management from the practice. I think, but it's starting hall to think of clever ways to do that. Okay, well, 2.5 minutes is over. Go to the next one. Okay, we have only 2.5 minutes. Sorry. Go ahead. Go ahead.
so ideal systems should reward clinical work or public health work or whatever it is. It might be process, outcome, it should be flexible and so on. But more we were talking about that it should reward improvement work, quality work, and things like participating in quality circles, taking responsibility for quality circles, or using data for improvement and learning or benchmarking or whatever. And we were mostly discussing about this. So it should be a balanced system which has both elements, and in a way recognizing that GP has 2 elements in his or her work. It is the clinical work, public health work, whatever it is, and improvement of that work. And we should emphasize this improvement part. You agree? Yes.
Thank you very much.
So, both clinical work and improvement work.
That should be incentivized. Okay, yeah, well, that was what we asked for. Thank you very much. Any more comments? We have still a half a minute. Okay, then I save time for the next group. The biggest group. So what came out of your group?
We discussed the whole concept of incentivizing for quality and whether we should be doing it or not. Interestingly enough, that in Latvia, we heard that as of July, they're beginning to start paying for quality. 13% of their salary will be for quality. But we really, I don't know whether it's my bad influence, but we really did discuss whether we should be paying for quality at all. Whether it's enough that the doctor gets a monthly, 3-monthly, yearly report on the practice, and whether that's enough. Whether we should be publishing the results for public to see. Whether it's a good thing or a bad thing.
You would like an experiment where you have these people paid this way and compared to other care, otherwise paid. And you believe that that would have better outcomes if you only pay the doctor.
I'm not saying it would have better outcomes, but I'm not saying it would have much worse outcomes. Because I think doctors will wish to see what they're doing. But I don't know whether they have to be paid for what they're doing.
Yeah, but with the mention that you are a policy advisor and you have to convince politicians that your idea is fantastic and resulting in clinical effectiveness, you think you will manage?
No, but I work in Israel, and in fact we have an enormous indicator. We're surveying roughly 75 indicators.
Okay.
And no doctor gets paid anything for the targets. And I would say that most of our figures are probably as good as the British.
Okay. Well,
And not only that, on Monday I was sitting in a meeting of a survey that was done of doctors by the Ministry of Health. They asked an outside group to check this, and most doctors are actually quite happy with the fact that they receive a record of their indicators.
Well, that's important information. It's actually what Martin Rowland yesterday said, that shaming and blaming is probably enough, you see, so that's...
But the one thing, and that, again, I have to take the blame for, is that the one thing that I think it was something like 85% of the doctors said that the one thing that they feel that should be measured is also the psychosocial part of the consultation.
Okay. And did they also indicate how?
No, we're working on that.
And any other comments from the group? You discussed the Latvian sort of incentive.
Yeah, we are discussing how this piloting thing. We are happy that those indicators would want to be mandatory. There will be the general practitioners who will be willing to receive this additional payment. They might be able to register for this, which is good. Because if it would be mandatory, we will not have this pilot, and we don't know what consequences this introduction of quality indicators will have at the end.
Okay.
But still, there's a lot. The doctors are not happy about this possibility to get additional money. They are opposing the Ministry of Health.
Sounds that we'll have the heart at the right place. I'm not so happy about that. Okay, thank you very much. 2.5 minutes for the last group.
So who's presenting? We didn't come in.
You need a microphone to get louder?
No, we were not. So we discussed the question whether we have the right set of indicators which are helpful to improve quality. So we were thinking the data set, the quality indicators that we are right now using are not sufficient enough. We need more indicators on this doctor-patient relationship level. And then we discussed some approaches which were helpful to improve quality in care from Germany. These quality circles, that might be an instrument which might be incentivized. So actually, these are two major points I had. Do we have further ones we were recommending to the people?
We were also discussing the aspect about, is there any need to add money for quality improvement? Probably there is some other motivators that will enhance the way that the teams work, and not only by money itself. So there should be a lot of research also done into internal motivators for the primary care teams to improve their own care, such as benchmarking, shaming and blaming, or whatever that could be. And done in some not a very offensive way, but I think there should be a lot of research in order for example, and focus that aspect, that countries that don't have a lot of money to invest in this kind of national quality improvement projects, that could actually have some other kind of resources to make it more thoroughly and more accurate.
Okay, well, thank you very, very much. That was the last slide. I missed that one out. The clinical factors, but that's ultimately what it's all about. That we have to have doctors who are clinically very effective, and how to motivate them. And I think, well, a lot of ideas have passed, and certainly money is not first on the list of motivators. And well, it was a very good workshop. Thank you very much. Thank you, Helen.